Having practiced in critical care for the past 10 years, my focus has been on mitigating perceived barriers to mobilization and rehab. Some of the things that we're doing differently at UVA in regards to bridging the gap for our heart transplant patients, the ones that require a balloon pump with femoral access, we just get them up and moving with an interdisciplinary team to ensure that it's safe and effective. We use a standing bed, and that standing bed allows that person to come to a standing position through verticalization, and through that, we're able to walk off the bed and start walking down hallways. We've had roughly 140 ambulation trials and roughly 200 meters per ambulation trial. The winner, per se, at this point is about 900 meters, and that's in one session. That's a guy who couldn't breathe before the pump, and now he's able to walk 900 meters with family. When I speak to different folks about what we're doing, it's often looked at as you're crazy up until we start talking about the evidence into that. The ability to ambulate these folks who have femoral cannulas as a bridge to transplant, our length of stay has significantly gone down. Some of the anecdotal benefits that we see as a result of being able to mobilize these folks, we can get our patient up for those daily standing weights, which is certainly fantastic for the docs who are looking for appropriate fluid management. But you also see all the benefits of early mobilization being compounded as well. Better vascular tone, increased muscular strength, the ability to communicate with family and friends at eye level. I mean, these are just things that are beneficial for the care of that patient as an active participant. And certainly the ability to get out of the bed affects the emotional and psychological component of their engagement in their care. If patients are strengthened and ready for the surgery, their time to home is a lot sooner. In trying to determine when they're ready to ambulate, we look at the patient as a whole. And if they can tolerate verticalization, that's what we'll start with. If they can tolerate rolling in the bed to get on and off of bedpan, we're assessing strength and ability to follow commands, that sort of thing. From there, we go to the verticalization piece, and if they can tolerate that hemodynamically, then we look at strength before stepping off of a standing bed. And from there, we're able to safely walk down a hallway with an interdisciplinary team. I think some of the biggest challenges we faced right off the bat was the bedside, because it's not something that's frequently done. The very first individual that we were going to get up and ambulate, we had gotten the doc's approval, and I had gone in there and spoken to the patient about that, but nursing was much more vocal and hesitant at the time. The next day he ambulated for the first time. The day after that, we walked outside. And so you could actually, it was palpable, the buy-in that became unit-based. Starting a program that requires mobilization with a femorally accessed balloon pump is truly a multidisciplinary opportunity. Having bedside buy-in was exponential, and having champions at different levels in order to help promote this was certainly an opportunity for us. Being able to go back to evidence to support moving forward is something that we use as a bridge to make that happen. Some of the things that we've implemented is in our EMR and to ensure that we have consistent care across disciplines. And through that, we have clinical assessments that nursing was doing anyway. Is the patient awake and able to follow commands? Insertion site, is that stable? Is there excessive bleeding? Make sure that there's a secondary anchor intact. Measure the tubing external to the patient, and that's from the proximal hub to the distal hub. If that changes, then we alert providers. Pulses, cap refill, edema, warmth of the both extremities. And we also look at radial pulses to ensure that the balloon is not migrated pre-ambulation. Post-ambulation, we go through some of those same aspects to ensure that there hasn't been migration and no changes clinically. If there is concern, there's certainly a post-ambulation x-ray, but we have not seen a lot of migration that is significant. Regarding infection rate pre and post the ambulation piece, I don't think there has been a significant increase, and I've not heard of that from some of our multidisciplinary team. I like to be able to practice at the top of my profession, and this was one of the opportunities to do so at our institution. The most persuasive piece of this is watching the patient become more actively engaged in their care. They have gone from passively participating in their care to a much more active and engaged component with family, with their caregivers, outside of the room. And so that's pretty powerful.